You're watching CTN, the Connecticut Network, connecting you to state government since 1999.
So we would just like to, I guess I'll kick off, welcome you to our meeting here at the end of July. And one of the things I would like to highlight is that this is our 1 year, July marks our 1 year anniversary. And I cannot believe it's been a year. It really has been in so many ways. But I'd like to kind of highlight some of the things that have taken place over the last year. With TCB, our Taking Care of Business, is the formation of our work groups, infrastructure and services work groups. They've been actively meeting since their formation. And I'd also like to focus on the fact that we had 2 large in-person sessions of TCB around level setting in January, but then most recently in June, the one that I was able to participate in on strategic planning. It was just a really very rich day, and the level of participation was so encouraging as well. And then we also released an interim report on the General Assembly website. So those are some of the things that have taken place over the last year, and just getting structured and having the involvement that we're having at this time as well, and the many different topics and input and data over the last year. Just to reflect, take a moment to reflect, and I just really want to take an opportunity to thank you for your commitment and your involvement, and to also say I'm so grateful for these 2 fantastic chairs with whom I get to serve, as well as in addition to Erica Israeli and the TAL team. So I just want to kick us off in that way, just to say happy anniversary. And next, whoever would like to go next, Cece.
There we go. So I just echo what Representative Exum said, because it has been a really great learning experience, and yet we are just baby steps into the process. And I'd like to think we were further along, but we're not. We're just still learning and gathering information, and we have a lot of work ahead of us. So thank you so much for being here and for being part of the work, and I will turn it over to Claudia.
Thank you, and it's just been a fantastic experience. I think one of the things we learned going through this session is having the built-in connections and network, and having the feedback process happening throughout the year makes the legislation and the work on budgeting and negotiating some of the items that are high priority to all of us much easier and intentional. So I just want to appreciate the fact that with the TCB, we've sort of had a 24/7 ongoing conversation, and we're able to refine and get better understanding, and it's borne out in real progress in just a short period of time. So thanks everyone for the commitment to now and all the work that's still ahead.
Thank you. Erica Nowakowski with the TAL Youth Justice Institute. We do need the acceptance of the May meeting minutes. Can I get a motion?
Second.
Okay. Any modifications, changes, revisions to the May meeting minutes? No? Anybody on Zoom? No? Okay, thank you. Can we get a vote? Acceptance of the minutes?
Aye.
Aye.
Okay. Thank you. So this month's meeting is actually a continuation. This is a 2 to 3 part meeting, discussion around the school-based behavioral health services. Last time we met, you received presentations from the children's, from CHDI and several other superintendents of the other districts, and providing you an update on the type of services that they're providing, as well as the type of needs that they have and recommendations. This month's meeting is focused on 2 specific areas as it pertains to school behavioral health services. One of them is the trauma-informed approaches in school-based behavioral health, and then the second one is the effective school solutions, insights, and findings. So I would like to first give the floor to Diana Perry from the Trauma-Informed Approaches in School-Based Behavioral Health.
Thank you so much, and I'm actually going to pass it off to my colleague, Kate.
Good afternoon, everyone. My name is Kate Erickson. I'm the Executive Director at LEARN. I have the distinct honor of representing the RESC Alliance today. The RESC Alliance is a partnership of the 6 regional educational service centers, ACES, CES, CREC, EastCon, EdAdvance, and LEARN. RESCs are not-for-profit, fee-for-service public education agencies with a mission to provide quality, cost-effective education resources, programs, and services to Connecticut's public schools. The 6 RESCs are spread across the state and serve every school district in Connecticut. Each RESC has a broad scope of programs and services that they offer to their geographic region in support of the entire educational community. Also important to note is that collectively we serve 14,000 students through our magnet school programs and employ over 2,000 educators. Overall, the RESC Alliance has a broad and deep expertise regarding Connecticut public education. But today we're here to discuss the RESC Alliance efforts to build and implement a statewide training and support system around trauma-informed care. In the spring of 2022, the Connecticut General Assembly passed a budget adjustments which included $1.2 million in funding for the 2023 fiscal year for the RESC Alliance to build an evidence-based program organically from the ground up. Immediately, each RESC hired a regional trauma coordinator to work as a member of the RESC Alliance Informed Care Collaborative Team to research, design, and implement this new program. Unfortunately, the $1.2 million in funding was not distributed by the state until the following fiscal year, which was the 23-24 school year. However, the RESC Alliance viewed this investment in trauma-informed care as an essential to school improvement. So each RESC financed the first year of this project themselves, and we utilized the $1.2 million to continue the work in the next year. The RESC Alliance and the Trauma-Informed Care Collaborative Team did an excellent job of developing a program and piloting the program. When the funding was finally released by the state, the RESC Alliance used it to offer programs across the state to districts at zero cost. This past legislative session, the General Assembly allocated a reduced amount for the fiscal year 2025 of a total of $500,000 for this program to continue into the future. It's imperative that the Connecticut General Assembly and the executive branch establish a standing general fund line item to continue this work at the $1.2 million annually. At this time, I'd like to introduce Diana Perry. Diana is one of our regional trauma coordinators who will talk to you about our first year of implementation of our professional learning. Diana.
Thank you. Hello, Diana Perry. I have a doctorate in clinical psychology. I'm a licensed professional counselor. I have 12 years under my belt working across the country as a clinician, working with adults in chemical dependency treatment centers, outpatient programs, students and families in schools. At the time in 2022, when I saw that Connecticut was maybe going to go for actually becoming a state that was trauma-informed, I was actually working for CHDI. I was helping them to promote the CBITS and Bounce Back programs to ensure that our schools had adequate training in trauma-informed evidence-based practices so that they can continue the work. And I was happy doing that work. But when I saw that the state was looking to actually have a free, equitable, trauma-informed care training program that could be available at any school in the district in the state, I knew that that was the way that the state needed to go, and I knew I wanted to be a part of it. You can click through the next slide. Clearly, the state knew that it was important because something came out, right? There was funds that came out, and there was a mandate that was stated in order for this to begin. So when we began the process of trying to figure out why trauma-informed schools matters in Connecticut, what we knew was, at that time back then, that 40% of adults in the state of Connecticut were reporting symptoms of anxiety or depression. These are our school staff. These are our psychologists, our support workers, our paras, our educators, our families, right? These are the people in our schools. We also knew that there were 49% at that time of youth in Connecticut in the age bracket of 12 to 17 with depression that were not receiving treatment. This is just depression. We're not talking trauma yet. That did not receive care. Of that 51% that did, 70% of them received it in schools. So we knew that our adults were struggling. We all know that our schools have been struggling before, during, and after the pandemic. And we also knew that they were doing the bulk of the work to try to help these kids that were coming back with more and more acute concerns. You can move to the next slide. So when we came together as a group, we have school psychologists, administrators, people who have worked in public health for years, myself, I'm a clinical psychologist. Well, I'm trained to be a clinical psychologist. We knew that the state wanted a training program that also had the train the trainer process, but we also knew where we were in the state when it came to those figures and the figures that you'll hear from Effective School Solutions in a little while. So we knew that we could not build something that was small. We knew that it needed to be individualized, resilience-focused, and it needed to take into account the strength, the capacity, and the limitations of the system that was reaching out to us. We could not give the same thing to everybody. We had to offer many options. So that's the choice we made. You can move forward to the next slide. We knew this because for those of us in the room who, we're all human. We've watched the way the world has gone in the past number of years, right? We're all here. You're on this committee because you see it and you want to shift it. We knew that it was more than just that inner circle there, teaching people the basics about what trauma is. We knew that we needed to help them to understand what the trauma response was, what the stress response is, and how humans, not just students, feel it, and how when systems or adults or others are feeling stressed by the things that are our reality. Everybody needs help, right? So we knew that we needed to build something for the state of Connecticut that would focus on everybody. That is the vision. You can move to the next slide. Thank you. So this is the program that we developed. These are the modules that we developed. Rather than staying with the Foundations of Trauma-Informed Care module, we also developed a compassionate leadership module that helps administrators who themselves may be strained by various barriers to understand how to implement things feasibly and effectively. We built a staff and systems wellness module to go beyond telling people to maybe take a walk or take a deep breath, to build in how to work as a system to hold each other up. That's why it's called Uplift. We're trying to lift everybody up. And then we built in a TIC and practice series, which is 6 specific modules geared toward each of SAMHSA's 6 principles of trauma-informed care, so that after they have some base information and a starting point for foundations, they can dig in using our assessment tools to identify which module or modules would make more sense for their district or their school or their team. We wanted it to be really thought out and robust because we thought if Connecticut was going to build something like this, it needs to be. You can move to the next slide. So how did we do? That's why we're here, right? We want to know, well, how's it going? I'm going to bring us back a little bit because everything I just shared with you was kind of like that first year, that development year. It takes a long time to build a program like this, right? You have to collaborate with so many different partners, and there's already so many different partners here in Connecticut that offer trauma-informed or trauma-focused things. We didn't want to step on anybody's toes because that wouldn't be trauma-informed. We also knew that we needed to hear from our students before we started to solidify any of those ideas that you heard above. So we had a bunch of focus groups with over 115 students. We walked them through the 6 principles of trauma-informed care. We asked them questions related to safety and trust and all of these things. And at the end of it, we asked them, what do you think? What do you think about this idea that Connecticut has? What do you think about the Uplift program and models? 95% of our participants felt it was relevant and was useful, and 95% of them saw value in it in their school becoming trauma-informed. They were on board. We had the kids. They had our backs, and they knew that we had theirs. You can move forward. So that was a really good sign for us. So we start the process, right, of trying to identify who might be able, have capacity, who might be willing to do this work. And this is who we worked with this year alone, with all of those concerns that Kate had brought up a little earlier. These are the schools and or districts who have reached out and done work in Uplift through training or consultation, implementation, things like this. As you can see, we have a wide range. They are scattered throughout the state. And we also do have partnerships with the American Federation of Teachers to offer training to their membership after hours when it's sometimes easier, as well as with Western Connecticut State University, who really is wanting to train their school and counseling students in trauma-informed care so that we have more workers entering the workforce with this understanding and this awareness. You can move on. At this point, we have forged partnerships, as you can see, with 25 schools, public school. Oh, I'm sorry. Can you move back to the last slide? Just so that 25 school districts or RESCs in the work. And within those 25 kind of like districts or partners, we have engaged 52 schools or departments in training and access to Uplift across the state. So for a one-year implementation with all these concerns going on, I think that shows, again, that there is interest in the state for something like this. You can please move forward. In terms of the trainings, when you break it down overall, as you can see, throughout just this fiscal year, we were able to do a total of 108 trainings, and we had over 3,000, almost 3,500 participants over the course of the year throughout the region. We broke it down by region for you as well so that you can kind of see the split, kind of where those were, where those participants live. And if we add in some of the trainings that we were able to do in the first year when we were also developing, you can move forward. We have had 4,311 people sit in a training with us. This does not include any of the group ad hoc consultation, implementation, support that we're doing. And this also takes into account, like let's say I have a team that did cultural humility module. They did it over 3 sessions, right? So those numbers there, how many in that first column, cultural humility 5, we accounted for the fact, we only counted 1, like how many teams completed a module. So that those numbers don't even show how many true sessions there were, just how many modules were completed. You can move forward. As you can see, we also had our trainee demographics were vast. The legislation asked that we, focus on clinical personnel. But as you can see, the interest and the need, there's a lot more personnel in schools and in staffing that want to know this material and want to learn this material. As you can see, we have a pretty mixed placement level. We've got a lot of different placements and levels. And so we just wanted to make sure that you know what our demographics are. You can move forward. In total, when it comes to all of our trainings and any feedback that we receive from them over time from participants, we are seeing very strong training and trainer feedback. 93% of the concepts in the sessions were relevant to their work. 89% of the participants stated that they can apply some concepts from the session into their daily work immediately. 90% stated that the activities and materials supported their understanding of concepts, and this was the ask. So that's another indication that we were on the right road. You can move forward. We wanted to share with you some of the statements that were also given. So we asked for quantitative and qualitative feedback for any training that we have. When you read something like, this is relevant for our district, school, teachers, and students, there were key components that were beneficial. The trauma glasses, which is an activity we use, was interesting and something that could easily be applied in my school and classroom. Information was highly relevant and valuable. I personally appreciated the information on brain research. We were getting a lot of positive feedback on this, and we utilized that feedback and other feedback mechanisms in order to improve and revise our modules this year, and we'll continue to do so. You can move forward. Overall, in terms of the regional trauma coordinators and where we're at, regardless of this, you know, this is what we would do if we were moving forward. If this Uplift trauma-informed care training plan does not work out for the state as a state-run thing. We would want to offer Uplift training and train the trainer opportunities for individuals that don't have districts that can support full implementation. There are a lot of districts and schools and interested individuals that reached out to us and wanted training and just felt like they couldn't do it with all the barriers and stressors that they were seeing in their schools and in their communities. It was like, it felt like another thing on their plate. If we could offer a statewide way so that anybody can get trained, regardless if their school or district could be a part of it, that could help as well. We're also really wanting to refine the way that we analyze and collect our data. We developed a dashboard that highlights district and community indicators that helps people assess their communities. We utilize quarterly and annual reporting structures ourselves so that we can report back to the state on what we're doing. We developed a trauma-informed care implementation assessment tool that's a 33-item measure that our teams use in order to, track where they are at. Smart action plans and lots of team-specific reports that we would like to continue to be able to refine. But ultimately, if we cannot secure adequate funding to ensure that this is accessible and can be expanded equitably to anybody who needs it or wants it, that is our ultimate goal, is to ensure that we can maintain that. I've had a lot of interest and people say, I would really like to do this, but I cannot even think of what would happen if 4 months from now, after we develop this plan, you tell me that it's over. So there's a lot of tentativeness out there around, do I do it, do I not? You can move forward if you'd like. That was really all I have. I know the last slide on this, which everybody will have, is contact information for every regional trauma coordinator in the state. But thank you.
Do you want to open it up for questions?
I would just like to thank you for the presentation and found it to be full of really interesting information that really tracks with so much of the information that I've heard, just been individual stories, talking to school districts, superintendents, but hearing what we were seeing is something that was before, but certainly we've seen exacerbated, as we know, and during that time. And here, as we are post-crisis, doesn't mean that the trauma doesn't continue to exist. And so thank you for giving us this information. And I think what I really appreciate is that this is a program that's easy for people to, it's built. So to have it accessible, especially during a time when we have shortages around resources, is ideal. And I did hear very clearly the ask for the 1.2 million to be utilized, to be something that would be sustainable so you could continue to offer this program. So thank you so much, though. I wanted to just give those comments.
So, I'm sorry. Sorry, Edith. I have a question, which is, I'm curious when I see 3 schools down in the Fairfield County area, and I'm just wondering how did you pick who was in this cohort of the participating school districts and partners?
I appreciate that question. We did not pick. We waited for people to say that they were interested because we believed, just like in many other areas, people need to be ready and interested themselves and not pushed or forced or have it marketed to them too much. So we had an interest forum, we would go out and do all sorts of presentations, and so those 3 areas that you're seeing, they came to us.
So it was a question of self-selection.
It was a question of self-selection. Had we, yes, yes. As we expand, maybe, perhaps it won't be, right? We can see that there are areas that might be able to use it, but yes, in the process of developing, you know, advertising it, trying to get it out there, yeah, it was self-selection.
Okay, thank you.
As a follow-up to that, how was the information marketed throughout the state?
Well, the state, you know, our state has a really wonderful set of collaboratives and all sorts of groups, community groups, lists, you know, that are already doing really good work to try to get information out to the people. And all regional trauma coordinators had, we know people, you know, we work together, we've been doing this. So we just went and talked about it with people. We just shared an introductory information about what the legislation was, what Connecticut was trying to do, what we were doing, where we were going with this, and that's how they got interested. That's how we found them. So it was a lot of collaboration with partners throughout the state. And we also built into our modules ways to reach back out to those partners so that they can, you know, they can also be aware of what's out there. I hope that answers your question.
It did. And just one other question around a school, like in my district, the American School for the Deaf. Would there be something that could be implemented there as well?
I would love for that to be the case. Our vision is that every school believes that this is important. I think one of the, yes, there's always a way, right? However, there's only so much that can be done without the proper funding. You know? But our training's already built, so if we had an interpreter, there would be no, I'm sure that there would be a way to get that information to that community. At this point, we don't have the solution.
Thank you so much. Are there any, oh, yes, go right ahead.
It's refreshing to hear you all talk about trauma-informed principles and implementation. Our agency is a huge advocate of that. Recognizing that if this is transformation work, right, it's a long process, and it's a process just to sustain it, right? On one of your slides, you stated that you offer the training and train the trainer opportunities for individuals that don't have district support for full implementation. What is the cost of full implementation per district? Do you have a number?
Right now, we were trying to keep it no cost. So right now, anything that we have done has been free. There has been no cost for any train the trainer stuff, any trainings, any implementation, any consultation. It was, you know, it was going to be funded through those funds. Right now, we don't have a cost associated with it.
So literally every school district in the state, if they wanted to go through the transformation process of implementing trauma-informed practices, soup to nuts, you all would cover that support and guidance through the entire process, which can be 1 to 3 years, I think.
Oh, yeah. That was the goal. That was the hope, yeah, is that we would be able to have a program that was available to anybody, that was, you know, equitably available. Nobody has to worry about that. And they can just go in and go at their own pace based on their own needs, their own community, and what they're seeing.
So just for a point of clarification, because I think this is an important one, it's not that your service is free. It's that currently the state is funding it through ARPA allocations. Is that right?
Correct.
Yes.
Correct.
So there would be pick up potentially opportunities for the school districts to elect to do that and to implement it, and we can find out presumably from you what the per unit cost would be. That would be really helpful if, you know, we decide on a per district basis or some other way of continuation. But I just wanted to make sure the service is at a cost. The state of Connecticut currently is providing those resources through the ARPA. Thank you, Edith.
We do have a question online. Javid?
Hi, everyone. For those that don't know me, I'm the chair and chief of psychiatry at the Institute of Living in Hartford Hospital. I also am a child psychiatrist. I'm also the founding director of a new research center focused on research on racial trauma and community healing here. I want to thank you for the presentation. I also moved to Connecticut because I believed in the potential of this state. But part of the challenge is that I'm also coming to terms with the reality of how vast and systemic the underfunding is of children's mental health in Connecticut. I am a big proponent of trauma-informed practices. I've done training, consultation, implementation of TIC in multiple sectors. My concern is that we might be conflating a few things as the same. So first of all, just for those who aren't as aware, trauma-informed treatment is not the same as trauma-informed care or practices. Treatment for people who have experienced trauma-related or stress-related disorders is delivered by licensed practitioners. Trauma-informed practices or trauma-informed care is a whole-scale paradigm shift in how we might be able to approach people who might have experienced distress due to adverse experiences in a more sensitive and compassionate way. But training is one component of that. And I think that this is a great best practice. And I love the evaluation. I love the dashboard. I love everything that you've done. My fear is, what does this actually look like in a school district that's underfunded, where there aren't adequate professionals to actually care for people for whom their distress is interfering with their learning? Their risk factors are piling up, leading to the possibility that it might need to have a crisis visit. You know, the challenge I have with all of this is there's an inequitable distribution of those resources because of how school-based services are funded in this state. And while training is something that's very, very important, and I think something we should continue to sustain and strive for, especially in line with the work that you're doing around coaching and implementation, there's a lot of people in a lot of districts in the state that I hear from where they just don't even have the basics to be able to think about this. People who are working in schools who are challenged because resources are cut, kids who are challenged because they're not accessing it, families that are having a hard time because they're dealing with intergenerational and structural trauma, things like poverty, etc. So it's just a bit of a reflection and a comment slash question, but I just felt compelled to share that all of this is great. It just doesn't really translate into equitable change the way that we need it. To implement trauma-informed care, we need to do it on a whole scale level. We would need to look at policy. We would need to look at legislation. We would need to look at how we're actually staffing these services, because you can't have people who are stretched, asked to take on more and more and more with less and less and less, actually implement something in a trauma-informed way.
If I may, as a person who runs schools and who has a school that has some big behaviors and some big needs, and I would argue might be underfunded, I would agree with many of the things that that gentleman just said. But what I would say, having a staff who just went through 2 different trainings with the trauma-informed care, the first one, I'll just be really honest, it fell flat. Because to be honest, people didn't have the capacity to absorb that information, and they really wanted, what does that mean for what I'm going to do tomorrow in my classroom? And we heard that, and we worked with our team, and the next full day training that happened got really granular. So one of the things that we we try to talk about in schools is there's only so much we control as educators. We understand that there are systemic problems in our society. We see that, we live it. But at the same time, I can't fix every aspect of the challenge. And we talk about that with our educators. What can they control? And what can they change in their mindsets in terms of how they approach children who we know have had a traumatic backgrounds? And so that has been really foundational for them to be able to then absorb the training and then say, okay, so what does that mean tomorrow morning when I open my classroom door? And so those are changes that are happening. And then if you also looked, he mentioned legislative actions. So our Connecticut State General Assembly passed a law around restorative practices. And that is part of trauma-informed practices that, to be honest, again, will fall flat unless we have context as educators to understand Why don't we have a matrix says, if you don't bring a pencil to school, you get a detention? Why don't we do that? Because that is not a trauma-informed approach. But that's not the way I grew up. I don't understand that because that's not my background. So I have to go through a learning process as an educator around trauma-informed practices to then learn about restorative practices and how that's going to change some of the systemic practices that happen in our schools that lead to kids being thrown out of school on a quick, you're wearing a hat, or, you looked at me funny. Whatever the issues are, we've got to get beyond that. But I 100% agree that this is not for schools to solve alone, and this is the beauty of this group right now, is that we have the right people at the table to talk about the components, and the bottom line is our educators are just one piece of the pie, and this team has done a beautiful job of trying to bring to them new understanding, new brain science, new actual practices that can be implemented in their classroom, or if you're an administrator, in your practices as you look at what we could traditionally call discipline and how we talk about restorative practices. So all of this information is interconnected and really, really important for us to see this system truly change. Thank you.
Question over there, Alice.
Thank you, Catherine, and hi, Diana. I think what you said, Catherine, is exactly right. There are definitely things that people need to learn and understand in terms of being triggered or triggering youth just by, just general behavior and, getting there. And I also appreciate the gentleman who spoke before around, that the training is just one part of it. And having done a lot of training across the state, the frustration of teachers of, how am I supposed to do this on top of everything else is really an issue. But I think that what we have here, and in the last presentation and this presentation, and much more, is the idea that the schools are where our kids are, right? That is where they are most of the day, every day, sometimes even after school, so that there is an importance to being able to be present in the school, and there's a gigantic impact that can happen that would relieve the tension of teachers who are trying to, be mom, teacher, guard, whatever, and plus they have to buy their own pencils, right? Let's be real. So, they're kind of resentful that they have to go into their pocketbook and go to Staples and buy pencils. So, the reality is that there is so much possibility in the schools to be able to do this work. And I know that CHDI and other agencies across the state have been working really thoroughly around, how do we acknowledge the work? And, you begin to look at chronic absenteeism, right? And, we find, down in New Haven, a significant number, I'm sorry, I don't want to give you an inaccurate number, but, a large percentage, maybe over close to 50% of our kids are chronically absent. But then when CHDI and other agencies start to do PTSD scales with whole classrooms, we're finding between 40 and 60% of the kids, am I off? Jason, I'm in the ballpark. 40 to 60% are scoring positive with post-traumatic stress disorder. Not they've been exposed, we're not talking ACE study, we're talking actual clinical diagnoses, right? So we have an epidemic, we have the location of where the epidemic can be worked on, and we have to begin to think about getting out of one payer paying for all of this. DSS isn't going to be able to afford to fix this as a problem. Bill Halsey's over there. I'm sure he is appreciating that statement. But the Department of Education can't do it. That we have to begin to braid and blend our thinking about what the services need to be within a school. And, I know ESS is going to present and do, work on their high fidelity. But I would even go further, too, is to say you need to deliver social determinant health health. You know, we do care coordination in the schools. That need is so extraordinary for just keeping the kid awake because they didn't eat anything last night or they don't have a place to sleep. So we have this opportunity to really dig into what can we do in our schools. And it takes it out of this very privileged, dare I say, white privileged model of 1 hour of therapy a week is the answer to the problems that our kids and families are experiencing, and brings it more into a population health model. And, you know, I think Diana and Catherine are exactly right. Training for teachers, as long as you don't overlap. Some of my staff have been in trainings where they're like, okay, you got 45 minutes of training and then get out. You know, like there's that because there's a burnout. But I just want to say to this committee, this is one of the most important areas of intervention that we can have for our children and families is in the schools. So that's not a question, I'm sorry, and I don't mean to, but I think that it's really important for this committee to consider.
Thank you. Kate, I can't see you up back here, but Kate, I'm from New London, and we work very closely together. I want to thank you and your team for all the work you're doing. And one piece that you didn't mention that you're doing is the prevention work. And that's really important, you know, working at the earliest stages around prevention and trauma, and I think that's something to highlight. And I was also going to state what Alice stated, that this is really an opportunity now to blend some funding, whether it be education dollars, maybe some DCF dollars, maybe even Office of Early Childhood as a prevention. So it's exciting to see the work of this committee and maybe being able to do it on a very practical basis right now.
So we are close to time. I do see Fran's hand up. So, Fran, I know that we're going to give you the floor a little later as well. Is that okay to say, reserve your question? Okay,
yep, sure, no problem.
Thank you, Fran. Appreciate it. Okay, we're moving on to our next. Oh, sorry. Apologies. One more. Oh, okay. One more question. Oh, sorry.
I just had one quick comment because I know we have to move on. I was thinking in terms of whether you're doing prevention. You know, there's different prevention models. Are we going to float all the boats? Are we going to address the leaky boats? Are we going to work with the boats that are sinking? And I think the information around reimbursement, for example, shows that we're not doing enough to help the boats that are sinking. I think in terms of the prevention model, I would prefer to see more targeted intervention. So the kids that are most at risk getting the service rather than universally deploying a service across all cities of Connecticut, as you were, I think, implying, Senator Maher. So just a comment, distinguishing the really, are we preventing, are we treating, are we targeting? Thank you.
Perfect. Thank you, everybody. We're going to move on to the next presentation. Thank you so much, our current presenters. Moving on to the Evaluating Outcomes Effective School Solutions Insights and Findings. I will give the floor to Mr. Young.
Thank you, Erica. My name is Duncan Young. I'm the CEO of Effective School Solutions. I'll introduce two co-presenters or ask them to introduce themselves. Allison?
Allison Whitman, licensed professional counselor. I'm an executive clinical director for ESS in Connecticut.
And we're really honored to have Dr. Linda May with us today from the Yale Child Study Center, the director of the Yale Child Study Center. Linda, can you hear us okay? I know you're on Zoom.
Yes, I can. Can everyone hear me? I'm delighted to be with you.
Thank you so much for the opportunity to speak with you today. We're very excited to talk to you today about some of what we're observing with respect to best practices in delivery of high acuity care in a school-based setting. We've had the opportunity to partner with the Yale Child Study Center over the course of the past couple of years to do a number of research studies to really validate kind of some of the outcomes and results that we're seeing within schools. Yes, Senator.
We're hearing that the Zoom quality, the audio quality is not great on the Zoom. So if everyone can speak as close to the mic as possible, that would be terrific. Thank you.
Got it. Okay, hopefully that's better.
Okay. It is.
Excellent. Okay, can we go to the next slide, please? So I'd like to share just a 30-second background of our organization. Effective School Solutions is a provider of high acuity school-based mental health services in Connecticut and across the Northeast. We were founded in 2009 as an offshoot of a private therapeutic day school. And our observation at the time was that, let's say, 30% of students who were being outplaced by their home district to our private school every year were students who had mental health, emotional, behavioral challenges that, while acute, they weren't so acute that they couldn't have been supported within the four walls of the traditional school setting if only better capabilities existed. So our mission is very simple. It's to provide K-12 districts with school-based mental health and behavioral support programs that help at-risk students reach their full potential. That includes students who are either in and out of district placement and their families in the district are looking to return them, or students who have potentially been identified as being at risk of placement into an outplaced environment. We support across all levels of care, but we really specialize in high acuity care, or what's referred to in a school-based setting as a tier 3 level of clinical support. Last year, we served over 6,000 students in 120 school districts across 13 states, including over 800 students in 21 Connecticut school districts. We have an in-state staff of 100 licensed clinicians operating in Connecticut schools each and every day. Next slide. This is a quick visual map of the districts that we work within across the state. As I mentioned, there are 21 districts. We have pretty good geographic diversity across the state. I think what is very notable about our district partners is the diversity that exists across rural, urban, and suburban dimensions, as well as socioeconomic dimensions. So Bridgeport would be an example of an urban district that we work with. Thomaston would be an example of a more rural district, and we work in suburban districts like Greenwich, Westport, and Madison as well. But we've had a really good vantage point to see what best practices are resonating in districts across the state.
And as Duncan previously mentioned, some of these, we serve students at risk of, acute mental health challenges, behavioral challenges, out-of-district placements, special ed classifications. We support youth that have chronic absenteeism, and as well as mental health-related crisis episodes. Next slide. So here we have a parent testimonial. This is a parent that has a child with ESS we've been supporting for the last 4 years. And this is a really powerful testimony from this parent whose son made a lethal suicide attempt 3 years ago. I would encourage the state of Connecticut to widen the reach of acute mental health programming like ESS. My family was lucky that my district had this type of support available. Without it, I don't know where we would be today. As I look at my child's peers who took the out-of-placement route rather than ESS, not one of them is back on track to graduate high school and attend regular college with their peers. The need for comprehensive, intensive, wraparound clinical supports in schools has never been greater.
And of course, as we all know, this is not just a Connecticut challenge. Youth mental health is a national challenge. This quote from the Surgeon General, which he released last year, I think is equally powerful. Imagine a high school with 1,000 students. Now imagine about 450 of them saying they're persistently sad or hopeless, 200 saying they've seriously considered suicide, and nearly 100 saying they've tried to end their own life over the past year. That is the state of youth mental health in America, truly in a crisis state. There's been a lot of conversation about whether or not we would see a bounce back coming out of COVID. And unfortunately, that isn't what the data supports, and it isn't what we've seen in Connecticut or across the country. The next slide really gets into some of the data on this. We're all familiar, I'm sure, with the statistic that 1 in 5 children nationally have a diagnosed behavioral health condition. Specific to Connecticut, 28% of Connecticut high school students report that their mental health was not good most of the time or always. 66% of Connecticut youth with depression did not receive treatment in the past year. That's 41st out of 50 states. 47% of female high school students in Connecticut felt sad or hopeless almost every day for over 2 weeks over the course of the period of study. So we believe that truly youth mental health is not just a defining public health crisis of our time and public health challenge of our time, but also a defining education crisis of our time. And the next slide really talks about why schools have gotten pulled in as a part of the mental health continuum. Schools matter more than ever when it comes to youth mental health, and schools have really emerged as a critical delivery point for mental health care. There's really 5 reasons for this. So number 1, students are more likely to access and complete treatment when it's offered in a school. As Dr. Forrester just mentioned, we have a captive audience when we have students in schools. They're in schools for the majority of their waking hours. We reference a study at the bottom of this page, the Jaycock study, which was done in the Recovery School District in New Orleans in the wake of Hurricane Katrina. And it showed that students who were able to access mental health services in a school were more than 6 times more likely to be able to access treatment and complete a course of treatment if that treatment was school-based in nature. Second, offering services in schools helps districts avoid costly outplacements. School districts, whether they offer direct mental health services or not, are already in the mental health business, because if they have a student with emotional disturbance that they can't service in district, they're sending that student to a private therapeutic day school at a cost to the district and at a cost to taxpayers. Third, schools are uniquely positioned to focus on prevention. A lot of what we're going to be talking about today is intervention, what we're doing to support those highest acuity students. Of course, what we want and what we need as a system is the ability for us to divert resources from intervention over time down to prevention so that we're meeting students before they get into that crisis state. And then finally, schools provide equitable access to care. And then finally, mental health, I think educators are realizing, is a critical foundation of the core mission of a school district to provide access to educational and academic outcomes. But increasingly, we cannot disentangle the academic outcomes that we want school districts to achieve without making sure that our students have a strong mental health foundation. The next slide really talks about some of the challenges, though, that schools are facing right now when it comes to delivering high acuity care in particular. So first, and if we can animate the slide here. First, districts really have an increased need to provide mental health support. There's a de facto mandate that exists right now for school districts to provide support in school. Second, the administrators that we speak to are reporting that the number of students with mental health challenges and the number of students with high acuity mental health challenges specifically is increasing rapidly, 10 to 15% every year. Third, some school districts have capability gaps in their ability to provide high acuity care. School districts, in our observation, do a really, really good job in supporting the needs of students with more mild to moderate challenges, but when it comes to those high acuity students, which we would think of as the 3 to 5% of students in a school setting that have the most acute challenges, that really requires a little bit more of a medical model of care. And that's something that school districts have not been trained or equipped over time to be able to operate. And then finally, as we've heard from a number of speakers today, all of this is taking place against the backdrop of an inconsistent funding landscape. There's not a single line item in a school district's budget to fund school-based mental health. So districts are really left to their own devices to braid and blend funding from across various sources to be able to figure out how they can offer these critical services on a sustainable basis. So if we dive in a little bit more to some of the challenges with delivering high acuity care, we kind of think of this as districts needing to transition from a traditional method of school-based mental health care, which might be focused on more episodic care or on the needs of students with more mild to moderate challenges, to really building out those capabilities either on their own or through partnerships to deliver those higher levels of care that can help students avoid out-of-district placements. Some of the barriers that school districts face on this are depicted on the next slide. Some of those barriers might be not really understanding what a good evidence-based model for high acuity care looks like in a school environment. Number two, identifying the right staff with the right experience. One of our observations over the years is that if you're trying to duplicate high acuity services in a school setting, you don't necessarily want to find individuals with a school background. You want to be recruiting and hiring individuals who are coming from residential, from IOP, from PHP, and from some of the higher acuity settings that are out there. Clinical supervision. A district can hire clinicians, but we need to make sure that the right clinical supervision takes place in the school to effectively oversee their work. When we talk about high acuity students, we also need specialized capabilities. We need quality assurance and quality management processes around documentation, compliance, and finally, we need systems for data storage and processes for progress monitoring. Not many districts kind of license and operate an electronic health record system, for example, so they need access to those types of capabilities. And as we've referenced a couple times here today, districts that are not able to service the needs of high acuity students in the school environment typically go down the route of outplacing students to external environments. And the statistics on this slide are very recent and I think very powerful. So this shows that Connecticut is now #1 in the nation in the percentage of special education students that are outplaced by their home district. So the national average is 2.4%. Connecticut is behind only the District of Columbia at 6.3%. And if we look at some of our surrounding states as well, Maryland, New Jersey, Illinois, Massachusetts, typically running in that 5 to 6% range. Out-of-district placements in Connecticut have increased by 50% from 2010 to 2019 at a cost of $700 million to Connecticut school districts and ultimately to taxpayers. And to be very, very clear, a therapeutic outplacement is going to be absolutely the right thing for many, many students. It's really identifying those students who can be treated and serviced in district in the least restrictive environment, which is what federal special education law really requires of our school districts. So how do school districts do this, and what do mental health best practices in a school setting look like? This is a view of a multi-tiered systems of support continuum for school-based mental health care. There are a lot of different ways to look at this. This is kind of the ESS version of this, but tier 1 would be our universal support. So this would include mental health related professional learning for teachers, clinical staff, parents, and caregivers. A lot of what the RESC Alliance talked about today with their amazing work would really fit at that tier 1 level. We're accessing and impacting all students by impacting all educators who service those students. At the tier 2 level, that's programming for students with more mild to moderate challenges, generally a less intensive therapeutic structure. As I mentioned before, school districts generally do a really, really good job at that tier 2 level of support. Tier 3 is the main focus of our discussion today. Tier 3 support is programming for students with the most intensive mental health challenges. It tends to be highly structured, longer in duration, and more wraparound in nature. And again, it's meant to service students that are returning from an out-of-district, who are at risk of an out-of-district, or even at risk of special education classification.
So what our tier 3 model really looks like in a school, we're servicing that moderate to severe mental health challenges. Those students are in our program, about approximately 1 year. It can be longer. Our clinicians carry a caseload from 10 to 12 students, and we assign those clinicians in that single building. We offer daily group therapy that's built into the schedule. We identify a designated space, we furnish it, so it's more therapeutic in nature, and it really provides a confidential space for therapy to happen. So we provide that group therapy, weekly individual therapy, as well as family therapy. The family therapy is a huge component to our programming. We offer bi-weekly sessions as well as weekly parent check-ins. We also offer home visits for that school avoidant population as well. We offer psychoeducation and a monthly parent support group for those parents in our program, and we've also extended that programming for parents district-wide as well. We do the crisis, urgent interventions, and push-in support for classrooms, and we offer the clinical supervision and oversight. So we have many layers of supervision and quality management, data storage, and progress monitoring of those clinicians and the work that we're doing.
And in an era of very tight fiscal budgets, the great thing about Tier 3 care is there's a built-in self-funding mechanism. So if we are servicing students who are either out of district and are returning back to their home district, or who have been identified as being at risk of going out of district. High quality Tier 3 services delivered in the school setting have the ability to pay for themselves, and in some cases even generate a surplus for a district that could be reinvested into some of those preventative types of initiatives that we know that we want to see. So this is a very simple mathematical example. If we implement, if a school district can generally implement a high quality Tier 3 program on their own or through a partner at a cost of about $300,000 to service 20 students, so about $15,000 per student per year. If 4 of those 20 students are students that are returning from outplacement at a cost of $100,000 per student per year, and if there are an additional 6 students that have been identified as being at risk of outplacement at a potential cost, and therefore a cost avoidance of $100,000 per year, that means a district can, via a $300,000 program, generate $1 million in cost savings and cost avoidance, which would be over a 3x return on that investment to the district's budget. That $700,000 surplus are dollars that could be reinvested in the form of preventative services. So we really look at, from a system standpoint, solving Tier 3 is a key aspect of solving the financial sustainability challenge with school-based mental health in general. If we can drive cost out of the system, and one analogy to think about is an unnecessary out-of-district placement plays the same role in school-based mental health that emergency room care plays in our overall health system. The emergency room in our overall system is a very costly, non-efficient form of care. And I don't mean to denigrate outplacements at all, but they are costly, especially if it is for a student that is not necessarily kind of in need of that, or could be serviced kind of within the home district. So really we look at solving Tier 3 as the key to solving the system as a whole. I'd love to turn it over to Dr. May, who can talk us through some of the collaborative efforts that we've had with the Yale Child Study Center. Linda.
Yes, thank you so much, Duncan. And the Child Study Center, we're just delighted to be collaborating with ESS around this very important work. I'm also presenting the analyses that were done by my colleague, Dr. Amanda Detmer. So since the fall of 2022, we've conducted 3 studies on the data that have been gathered by ESS with their involvement. The first is asking a very basic question. Do these services positively impact grades, discipline, and attendance? The outcomes that we would all be wanting to see. The second is, do we have a relationship between the dose, if you will, between Tier 1 and Tier 2 and the results? And then the third question, which is one that we're very interested in broadly, of how mental health, physical health, and other metrics come together, is do these services impact non-school usage of, for example, high acuity mental health care? So let me go to the next slide. So addressing first the basic outcomes. These are looking at 169 students who received services high fidelity, model implementation, and we can go into the details of how that high fidelity is defined, but these are what we see. There's an average increase in GPA of half a letter grade. Even perhaps more dramatically, there's a 60% decrease in disciplinary events, the kind of events that often get children referred for out-of-district placement. And also a 50%, cutting in half the decrease in absences. When you cut the decrease in absence, children are there, they're able to benefit more from educational programming, they're present in the school, present in the community. These are really important metrics of the impact. Also, if you compare across, not shown in this slide, but if you compare across the different tiers of care, there is an impact at lower levels of care, but not nearly as dramatically as we're showing here, but there is an impact. You go to the next slide. Looking at healthcare utilization. Nearly cutting hospital stays by over half, a 50% reduction in hospitalization stays. Those are costly for families. They're costly to our healthcare system. And as we all know, there's often a shortage of availability of healthcare resources. Please go back to the next slide. There's also a 23% reduction in intensive outpatient referrals. And finally, actually cutting in third in the weeks that are in the high levels of care. So there are impacts also, intervention in the school on utilization of healthcare, bringing those two together. Now, Duncan, may I turn to you for the next slide?
Thanks, Linda. Yeah, the next slide was not part of the Yale study, so I'll speak to that. But part of the data that we collect internally is how effective are these services in actually helping to avoid therapeutic outplacements. We look at this in 3 different ways. So when a student, when we do an intake with a student coming into the program, we collaborate with the district and we identify them as a student that was potentially at risk of out-of-district placement. And that is, as you can see, kind of at the bottom of this page, that was about 127 students in Connecticut. Of those students, only 7 ended up eventually requiring an out-of-district placement, so a retention rate of 94%. If we look at all of the students that we serviced in Connecticut, 830, we had a 97% retention rate, and for the students that actually returned to Tier 3 programming in their school district from an out-of-district placement, there was a 100% kind of success rate in keeping those students in district. So 3 different ways to cut the data that really kind of look at the same result. The next couple slides I'll go through very quickly. These are very, very valuable services for parents as well. The quote that Allison shared before, I think, is indicative of the high emotion that really goes into these services with parents and caregivers. Obviously, having a child with a mental health challenge doesn't just affect the child, it affects the entire family unit. And you know, these services, particularly when they're delivered in schools, really serve as a lifeline for our families and our parents and our caregivers. 94% of students receiving Tier 3 services as part of this study saw improvement in their child. So great to see that it's not just school-based outcomes, it's also those home-based outcomes that parents are observing as well. 2 case studies, just to make this a little bit more granular on the next 2 slides. And this is an example of an urban district that is implementing services at the Tier 3 level, and then a rural district. So Bridgeport Public Schools has been a partner with us since 2021. We have a 14 clinician team providing Tier 3 care across the district. Some of the outcomes that the district has seen with these services: 65% of low-performing students, meaning a GPA of less than 2, increased their GPA by at least half a letter grade. 77% of students with disciplinary challenges showed significant improvement, and 56% of students with chronic absenteeism showed significant improvement, which is defined as an improvement of at least 3 absences in a given marking period. Bridgeport is a good example of a district that is working comprehensively and at a systems level to try to bring students back to benefit from in-district programs when that's therapeutically appropriate for the student.
Next slide, please. So the next case study here is Thomaston Public Schools. Thomaston Public Schools has been a partner with us since 2015. Very long-standing, great relationship. We have 4 clinician team currently there providing care across the district. These were some of the outcomes from the last year. 100% of the students with low GPAs increased by at least half a letter grade. 3 students returned from out-of-district placement, so that's 10% of the total students served. 84% of chronically absent students were substantially improved in attendance, and 94% of parents saw improvement in their child. Francine Koss, superintendent, provided a quote here at the bottom. Thomaston Public Schools is proud of its therapeutic program with ESS. It allows our students to remain our students while receiving the specialized attention they need to learn and grow from kindergarten through grade 12.
And we'll wrap up today's presentation with 2 policy recommendations. As a preface to the policy recommendations, I'll share a perspective about where we really see the landscape of funding going for school-based mental health. As I mentioned before, services today for school-based mental health are really funded by districts using their traditional sources, their local funds, their state funds, and federal funding sources like Title I and IDEA. So this is a very heavy burden to put on school districts, especially when many of these services are often substitutes for care that students would otherwise be getting outside of the school setting in the healthcare system. So what we see moving forward, and what I think is starting to be demonstrated in some other states across the country, is more of a blended model of how school-based mental health is funded. So this simple illustrative graph shows that today we have 100% of school-based mental health funding taking place via the district. We would actually see that over time beginning to change, where the district pays for a portion of these services, but if there are reimbursable services covered by Medicaid and covered by commercial insurance companies, that providers can get in network with insurance companies and receive the necessary licensures to do Medicaid billing on behalf of districts, so that costs can be covered that way and those savings passed along to the school district. We also believe that there is an opportunity for seed funding to be used to help incentivize districts to create their own in-district therapeutic programs if those programs can be demonstrated to reduce therapeutic out-of-district placements. And if we go to the next slide, that's really what the first policy recommendation kind of consists of. This is a policy recommendation to create financial incentive programs to encourage districts to build in-district therapeutic programs to reduce outplacements. So right now, districts do not have strong financial incentives or often the necessary seed funding to build their own therapeutic programming or to work with partners to do so. So the suggestion here is to offer districts one-time grant funding of $150,000 to $300,000 to build therapeutic programs that have a specific goal of reducing outplacements. So the idea is that that funding gets the program stood up in year one, identify proof of concept, identify that the programs can be self-sustaining through the return or avoidance of students from therapeutic out-of-placements, and then couple this with strong statewide reporting on outplacement utilization. One of the things we would love to see in the state of Connecticut is a statewide outplacement avoidance scorecard. If this is something that our policymakers in the state are identifying as an area of improvement, let's measure it and track our progress in improving outcomes. So again, district seed funding would serve as a bridge for school-based services, and the district would take over by self-funding those programs with tuition offsets in year two. So the math on this, which is not on the slide, if this was going to be done statewide and if 50% of Connecticut districts opted into this at an average grant cost of just over $200,000, that would be about $13 to $15 million over the course of a year. But if we compare that against the $700 million that's being spent currently on outplacements in the state, high potential that there would be a very, very strong ROI for school district budgets and taxpayers on that investment. The next policy recommendation is to pilot in an even more systematic way the implementation of high acuity school-based mental health care across multiple educational environments. So states like New Jersey and Pennsylvania are in the process of allocating budget funding to pilot high acuity school-based mental health care initiatives. These pilots include a research partner and an evaluation of educational and healthcare outcomes. And the idea here is that you would look at some of the measures that we talked about earlier today, but you would also go in and look at this on a population basis through a fiscal lens and really look at the entire system and understand via this study how are we doing with respect to overall costs in terms of the overall healthcare delivery system, in terms of helping to generate a return on the delivery of these services. So the suggestion here would be to identify 4 districts across the state, representative of all of the geographic and socioeconomic diversity. And you could do these pilots for probably $300,000 to $400,000 a piece if you're including a research partner. So you're talking an overall amount there of approximately $1.5 million to implement a pilot like this, but with the idea that you are getting line of sight into a return that could be scaled at great benefit to the state over time. The final slide just includes a couple of quotes talking about the power of Tier 3 services in the school setting. I'm not going to go through these, but these are available for you to review at your leisure. And it's been a real privilege to speak to everyone today. I really want to thank you for your time and your attention. Thank you.
Okay, I have lots of questions. So, of the 800 students you're serving in Connecticut in 2023, How many were you serving in Connecticut before 2023? Do you know?
We have probably been in that 600 to 800 range for the past few years.
Thanks. And then what percentage of the 6,000 students that you have served across the country are moved into outplacement? Do you have a number on that?
The overall statistics really mirror the Connecticut data. I don't have the exact number, but it's really in that 95. Our retention rate across all of our states, not just in Connecticut, would be about 95 to 98%.
So 5% get moved into
That's
an
correct.
outplacement
That's
eventually,
correct.
or at some point. Okay, sorry, I'm trying to go fast, so I know others probably have questions. Are these services currently available? Are these the same type of services that are currently available in school-based health centers? Because many school-based health centers have behavioral health services. So how is that correlation?
That's a great question. So we work in a number of districts that also have school-based health centers. And so if we think about that pyramid that I shared before, generally the school-based health centers who do amazing and great work would be operating at that tier 2 level. The programming at a tier 3 level would be more comprehensive. So one of the ways that we look at the data is the number of therapeutic touch points per student per week. As an organization, we average about 4.5 touch points per student per week at that tier 3 level. Generally with a school-based health center, that might be an individual therapy session kind of once a week, which is absolutely the right level of care for a student with a more mild to moderate challenge. Our observation is that at a tier 3 level, those more acute challenges really need more of that wraparound form of care over the course of a school week. Anything you'd want to add on to that, Allison?
Yeah, I think also, we're case managers a lot of the times in the schools and supporting the family. The family work is a huge piece of what we do. The family sessions, the parent psychoeducation, the parent support groups, going into the homes and supporting the family in the home separates that. So we really provide that intensive wraparound support that you might get from a student being in an IOP. I like to say our services kind of mirror intensive outpatient groups and to that capacity. So
that would be where your 4 touch points would be, including the home. Okay.
Yeah.
And then, thank you. I'm sorry, I'm just trying to go fast.
Okay.
Your data showed 50% increase due in Connecticut in terms of students needing services. And I'm wondering if that high number of 6.3 or 5%, putting them just after, as second right behind DC, I'm wondering if that's because Connecticut is known to be a provider and parents actually choose to move into Connecticut because of that. I'm just curious anecdotally if you have any knowledge around that.
I think that is I don't have any direct data on that. I think that certainly could be the case or a part of this. Allison, do you have any thoughts?
That's okay. You can get back to me. And then 2 other things real quick. One, how many students are you serving in Bridgeport right now?
Last year we serviced probably close to 150 students in Bridgeport.
Okay, because I was curious what percentage of the 800 you were serving in Connecticut were actually in Bridgeport. And then the last one is availability of workers. Were you were going to go there? Sorry. Yeah, I mean, it's a wonderful concept. I'm wondering where we're going to get the mental health, behavioral health professionals. So, and I know you probably don't have that answer, but I just wanted to throw that out there.
Yeah, it's the labor challenges in behavioral health. I think we're all kind of aware of. As an organization, something we've made a tremendous kind of priority on. So we have a 7-person team where all they do is identify and recruit great, high quality staff members. I mean, one of the policy things that we're seeing in other states is the use of subclinical positions. So California is an example of a state that has created a new licensure type called a wellness coach, which is a bachelor's level, not a master's level individual, but there is a formalized statewide certification that's being rolled out kind of as we speak. And the idea is for wellness coaches to be able to go in and do certain subclinical interventions that aren't truly therapeutic, but they can facilitate psychoeducation groups as an example. So that is one state's kind of initiative to help address some of the supply-demand mismatches that are taking place on the labor market. But great question.
Thank you. And I apologize to everyone for asking so many questions, especially to Senator Austin. We didn't stay with our 2-question rule, so I apologize.
We're sitting over here now.
Okay.
Yeah, so I wanted to say too, we did invite Fran Rabinowitz as a representative of the CAPS, and to make any remarks or be available to answer questions from the other districts where the program is being implemented. So just in case you wanted to let you know too.
If I may, and I really appreciate this presentation because I can see where there's real room for this to put into the schools or have more presence for the more acute care. I'd like to know what it looks like when you say the 4.5 touch points. What does that look like? Because I know what a therapeutic model looks like, and they're there all day. And I understand the educational piece sometimes is not the biggest priority. Getting the kids stable, I think, is the priority at those schools. So I could understand the grades being higher if they're in their schools. But what does it look like with the 4.5 touch points?
No, thank you for the question. So we subdivide that tier 3 level of care actually into 2 sub-levels of care. So we have a tier 3A and a tier 3B. I'll talk about kind of each of those and what that looks like. Tier 3B would be more of a traditional district self-contained program. That's not something we do a lot, but that would be kind of a separate room or a separate part of the building where a district would be providing academic staff and we would be providing a therapeutic component. So in that situation, those students are in that space pretty much every day, and we would be providing the model that Allison described before. Generally, what we aspire towards, and sometimes we have scheduling challenges that interfere with this, would be daily group therapy, weekly individual therapy, biweekly family therapy, at least a weekly check-in kind of with parents and caregivers. Those are all the scheduled interventions, and then we would have all of the non-scheduled interventions, push in, pull out, to be able to work with students on a one-to-one basis when they go into, when they have a crisis or when they have a need. Tier 3A is a model that we really advocate, which is that wraparound model. Think about that as a mental health elective that's offered within a student's school day. It's built into their schedule, and they might have English, they might have math, they might have social studies, science, but then they would basically have a space in their schedule for their ESS time. It would be for their tier 3 care where they would go every morning and receive group therapy. They would have that weekly individual therapy session, and it's done in a very discreet way with kind of students. So we like that model because it's supportive of the federal mandate that school districts have to support students at the least restrictive environment. So we don't want students to be in a self-contained classroom if we can support them in more of a mainstream environment. I would estimate that of our tier 3 care, probably 85 to 90% of that care is at that tier 3A, less restrictive level, and about 10 to 15% of the care is in a little bit more of that self-contained type of environment.
Thank you very much for that. Oh. Thank you. We're recognizing we're freezing is what this is all about, but it's so...
Is it cold? Got it,
It's
yeah.
so cool.
That blanket looks very comfortable, by the way. So.
She's just using it to promote Eastern Connecticut. I see all those great places, Senator Austin, always the champion.
And just the other idea, just to echo what Senator Marr said regarding the staffing, I would think I could understand that sub area that you recognize for students who might need less level of care between this in this acuity segment. But I think looking at what we're facing around workforce shortages, just imagining having the volume of professionals that we would need would be really a concern of mine, just to be sure that they're at that level of expertise, I think is really important. But I do believe that therapeutic schools, some of them are very effective and some are less effective. And that's something to look at altogether. That's something I've have some experience around seeing and have questions around. I like the idea of doing something within district if possible, understanding the staffing piece. The amount of time in a therapeutic school can look different. It looks like the amount of hours and touch points is more, just because that's what they are, that's what they do. But I certainly see a place for this. So thank you for the presentation.
Absolutely,
very
yeah,
interesting.
our pleasure.
I don't want, Claudia, go right ahead.
Thank you. First, let me say, I think you all set the new gold standard for coming in with the evidence and giving us a real elegant breakdown of the intervention and the outcome, and bringing the evidence to show that there's really an ROI. I think that's so important when we think about scarce resources and where we can commit dollars that have a ripple effect and allow communities and school districts to reinvest. I think that certainly sets your intervention apart. So thank you for that. I want to focus a little bit on sustainability and how that may look in Connecticut. So my understanding is that 21 district level schools, towns have committed resources to initiate ESS. Can you tell me what was used as the seed funding or the initiation funding in those towns? Is it local ARPA dollars, the local federal recovery dollars?
Yeah, so for a portion, many of the districts on here have worked with us since 2014, 2015, well, kind of pre-ARPA. And so generally that would be a very common source of seed funding, especially in the early days of ESS, would be going down that outplacement returner route. So if a district business administrator is doing their budget every year and they're seeing that tuition line on their budget go up by 5-10% per year, and we've all seen those school district budgets. A lot of times they've looked at that and said, okay, if we can bring, the ROI on bringing a student back can be very powerful. If you can service students in district at $10,000 to $15,000 per year, and you otherwise would be paying $120,000 per year inclusive of transportation to send that student out, a lot of times those districts were able to find that seed funding from out of district tuition placements and reducing that line item in the budget. We have some districts who came in using ARPA and ESSER funds, and one of the big focus areas for us as an organization over the past probably 18 months has been working individually with each of those districts to help them identify a sustainability plan moving forward. And so that could be partnering with them to identify grants that can help fund the work. That could be a lot of districts maybe came in year one using ESSER funds, but they didn't focus on that out-of-district placement tuition reduction aspect. So we work with them to put that in place and identify students who can be kind of responsibly returned. And one of the things we also try to do is to educate them on school-based Medicaid. As I'm sure everybody on this committee knows, districts, just to be blunt, capture pennies on the dollar when it comes to school-based Medicaid. Our school-based Medicaid structure is very, very challenging for school districts to implement. Connecticut is a district that has not yet expanded school-based Medicaid to service mental health care for general education students. 20 states nationwide, including New Jersey most recently, now can use school-based Medicaid to cover gen ed students. In Connecticut, it's only special education and 504 students. So school-based Medicaid usage and educating them on how to put that in place would be another sustainability step that we share with districts.
So then just following up, and I think there was a piece of legislation introduced this year in Human Services that would at least started the conversation about how we can expand billing. And a piece of that did survive is that we're able to bill outside of their IEP plan. So that's an incremental step that we're looking at, and maybe that would be something we can bring back. But what is, of the 21 districts that have found the seed money, have they all sort of committed multi-year to sort of sticking with it? And the reason I ask is because the policy recommendation that you made is interesting because it's proposing to us that if we have one-time money, that there will be an intervention that could stick, and that would provide the priming of the pump that the local districts will then see the ROI and have the offset, since they're the ones saving the money, to keep this going. And I think the only thing we need to know from that is how likely is it to be one-time money where it changes behavior and it actually allows the school district to step up after that first year?
It's a great question, and I think the devil is in the details and how the policy is constructed, implemented, and rolled out. And so the question I would have, and I think it's a really interesting kind of thought process, is thinking about what can help what kind of plan would we be asking of districts to solidify their commitment that there is an evidence-based program being implemented that will have that kind of desired result, and that commitment that if they do receive those savings in kind of year one, that those savings wouldn't be diverted to something else, but they would go to continue the program. So I think it's a great question. I do think it's solvable with crafting the policy in the right way. And this was obviously a very surface level piece. There's a lot of other detail here. Be happy to talk through it.
Thank you. That's very helpful. Yeah. Appreciate it.
So can we go to the Zoom first? Okay. We have Representative Walker and then Representative Nuccio.
Thank you very much, and I'll try and do rapid fire also. In your presentation, you talked about, I think it was Bridgeport, you said about 127, and then last year or this year, you had 160 students, and they were in outplacement. Was there residency in those outplacements, or were they just day programs?
So the representative, I just want to make sure I understand which number you're referring to. This is on the Bridgeport slide?
Yes, yes.
Yeah, so our understanding in Bridgeport is that the district as a whole has approximately 300 students that are currently outplaced to private therapeutic day schools, other non-public schools kind of in the area. The number that I referenced of the approximately 150, that's the approximate number of students that we serviced in total in the district kind of last year. Those are not students that necessarily had returned from out of district. That focus on the out of district component is something kind of newer that the district is kind of pursuing and looking at moving into this school year. Does that answer your question?
Okay, so none of the ones that I think so. None of the programs, none of the cities had residential placement. Is that correct?
I believe there are residential placements for students in the city, but I'm not sure whether or not that is part of the 300 number that's on this slide. I would assume that that's a portion of it.
Okay. And then you talked about the $700 million in your oversight of approximately how much Connecticut spends with this population of kids. Where did you get that number from? How did you come to that conclusion?
Great. So the 700 number, and you're gonna test my vision here and my ability to read the fine print at the bottom.
I'm sorry.
But this is the NCES Common Core of data. I'm happy to get you some more information kind of on that number, but the source is the NCES Common Core of data from 2021.
2021.
Yes, ma'am.
Okay. And yeah, I would, if you possibly could forward that to the administrator so that we could all get that information. I think I would appreciate that. And then finally, who oversees the ESS? Who do you get certified through? Do you get certified through State Department of Education, Department of Public Health, Department of Children and Families? Who oversees your certification?
Yeah, so in Connecticut, we have a psychiatric outpatient clinic license for adults through the Department of Public Health, and are we're in the process of finalizing licensure through DCF for a OPCC license. So DPH, and we have DPH because we have some students on our caseload over the age of 18. So the state requires us to kind of have that license in place. We've never traditionally been required to have the DCF license. We're putting that in place right now to be able to offer an additional service to our district partners of directly billing Medicaid on their behalf and passing those savings back to the school district.
Okay, so you don't have any oversight over State Department of Ed?
We do not have we're not required to have a license through the State Department of Ed, correct?
Interesting. Thank you.
Yes, ma'am.
Representative Nuccio.
So I'm going to call into question here my Tammy Wonder Twin powers here with Tammy and point out that this is not Kathy Austin's forum. So this whole 2-question thing, I'm kind of like skipping that, Y'all know I have questions. So I do have some questions.
Just letting you know.
Some might not be as popular, but I have a few things as we're going through this presentation that I wanted to specifically talk about. One, in regard to the funding. You notice Tony had questions, I have questions, the appropriations people. And Tony had a couple of mine, so I can cross those off my list. But one in regard to the funding, I just want to talk about very briefly. State of Connecticut just had municipal budget elections, and I think the majority of towns had issues passing Board of Ed budgets this year. Board of Ed budgets went up very high for lots of reasons, and a lot of towns denied them. One of my towns had an increase in special needs of between $600,000 and $700,000, was voted down. And our budget here in town was voted down multiple times for increases in the Board of Ed. So I do not like the idea that this would be funded via any sort of local taxes. And I'm wondering why we're not looking for near 100% reimbursement between commercial insurance and Medicaid payments, why there is still a 40, it was only 30%, so 70% of it is still being asked for at the town or state level.
Representative Nuccio, we would love to see 100% reimbursement on the part of Medicaid and commercial insurance. I think when we've looked at the math on that, it's really a function of Medicaid rates. And I think commercial insurance companies, to be honest, are in different places with respect to kind of attitudes and beliefs about funding school-based mental health services or mental health services that take place kind of within the school setting. So if there's a we believe that the way to probably fund services at a tier 3 level would be maybe a little bit less of a fee for service and more of a per member per month, per patient per month type of model. And that's 100%. I'm in alignment with you that that's where we should be going. I think it's a matter of getting Medicaid rates at the right level and helping to get the buy-in from the commercial payer sector on that as well.
So I understand that, right? But I think the problem is then you're asking local taxpayers to fund mental health services. And I can tell you when I've talked to plenty of residents in my towns, there was no appetite for the majority of residents to be paying for mental health services for other people's kids, right? Hate to say it, but that's how it was put. I think that's going to be our pushback. And if this is going to be an initiative, then we would need to look for the state to try to find some supplemental funding here, because if this becomes one of the items of a budget and a budget gets voted down multiple times, right, we're relying on town budgets to pay for this. And that I think is extremely problematic, especially because it's a service for a few and you're asking for the whole town to pay for it. So I think there's going to be some issues around the funding model. And kind of sticking with that same kind of logic, and looking at your presentation, the 4 points, like the group therapy, the individual therapy, and the family therapy, all of this is occurring during the school day. One of my towns, we have it's like a college model for classes. There's only 4 classes in any semester that's run like a college. It's an hour and 45 minutes a class. And there are no study halls, right? There's no study halls. They have 4 straight classes. So in this case, you're talking about taking a kid, daily group therapy, individual therapy, family therapy. That's an awful lot of learning loss time. So how are we accounting for that? I hate to be the damper in the room, but Connecticut's test scores are pretty bad. If we look at a 63.9 average for English and a 61.6 average for math with a 75 average, a lot of towns are seeing significantly lower. So how are we, taking kids out of class for all this time? How's that balanced with education, learning, and loss?
Great questions. I'd like to go back and just make one comment on your first question. The other thing I think it's important to realize when it comes to paying for these services is probably bifurcating students into your general education population, your special education population. So for, under the Individuals with Disabilities Act, if a student is classified as emotional disturbance and these services are required kind of under that IEP, that would be, I think, the situation where there's probably a stronger argument for the district to pay for that because they're receiving federal funding through IDEA to provide kind of those services. So I did want to make that one just distinction with special ed versus kind of general education. With respect to the learning loss time, I think it's a great question. In reality, when we're in a school district, this is a little bit of a negotiation. It's a back and forth. If you think about daily, the reason we have 4.5 services per student per week and not 9 services per student per week is because scheduling and the need for students to fulfill their academic commitments often is something that we absolutely have to take into account. And we don't want to, we don't want students kind of having to cut electives either, because their electives might be one of the reasons that they're coming to school and what's really causing them to kind of engage with their school. Maybe it's art or music. So that's really a careful discussion that we try to have with school district partners in figuring out what that looks like and being as sensitive to the schedule as we can. The other point that I make on that is this is a trade-off. It's a balancing act because we want students to engage with their academics and improve their test scores, but sometimes the most efficient way to do that is establishing a level of mental health stability that allows them to engage with those academics. If we're going to put them in their English class, but they're dysregulated and they're not able to kind of engage with their academics, we're not going to get that outcome. So it's really a trade-off and a balancing act, I think, between those two aspects. Allison, anything you'd like to add?
Yeah, I think we're very thoughtful about that. Academics, we are in the education system, and, to Duncan's point, they're not available for learning a lot of those times. So we try to get creative. I think in the middle schools, it's probably the most difficult challenge to schedule, but we're not pulling for full class periods. We're not pulling students from classes that are typically that they're not doing well in or they're not thriving in. We're not going to repeatedly pull a student from a core academic class. And it's a lot of conversation with the teacher about, the necessity for that. But many of our partner districts were built into the schedule. I think there's a few districts where they receive credit for being a part of our programming. So I think that with that being built into the schedule, the group is built in, then we're just pulling them for that individual therapy once per week. And then those PRN sessions where the goal is to de-escalate and then bring them back to class and get them back so they have increased seat time.
Okay, I think that's good information because the learning loss aspect of it is definitely a concern. We've seen a lot of learning loss in the last few years and we can't keep going down paths that are going to not try to get the kids back on schedule. And then let's see, the last thing that I would have is, I'm gonna be honest with you, I've talked to a lot of superintendents who promise a lot of things about cost avoidance and never deliver. And say, well, we're going to do this, we're going to spend this money, and it's going to save us money. And then the Board of Ed budget continues to go up all the time. So I would like some more firmer structure, some more firmer numbers, some results to show the potential avoidance. Like, how are you classifying that? What are the parameters, and how are we seeing it? Because special ed costs are all over the place. They kind of go up and down when somebody goes out, when somebody comes in, when somebody leaves a district, when someone comes in a district. And like I said, I've heard so many superintendents talk to me about cost avoidance, but yet the budgets continue to go up. And that is, again, something that I hear every budget cycle in the towns. So bringing forward those voices, I would not like to see something more definitive about how you're classifying that, because that was a big piece of your financial model also.
If I could at this time, and I appreciate Rep. Nuccio, I just want to move us back on our presentation a bit. As a reminder, we're really looking at different ideas, strategies, suggestions that are taking place. And these are our guests coming in to just give us a different point of view, ideas. And what I'd like to do is, it feels that this is not an appropriations meeting at this time. It's really looking at the behavioral health model. And I just wanted to bring that out at this time because we have other people presenting as well. And I want to give everyone an opportunity to speak. But one of the things that I did want to really put a fine point on is when looking at a program like this, we are talking about high acuity and trying to keep students, it's the proposal, in the schools where they may be able to participate. And if you have a high acuity level, the ability to learn at that time is not the first priority. The first priority is to become stable and whatever it requires to get that stability so that the child can learn and achieve. To put a child into a situation where they're taking a test or being in a classroom and they are not stable makes it much more difficult, which is probably why you see the rates lower at the therapeutic school. So I just wanted to kind of refocus us for a minute, give the opportunity for the other individuals who would like to make comments on this, but I always want to keep us very mindful around the behavioral health piece of this work.
Yeah, I just want to say, Tammy, I agree, right? I think it's a good model, but I think these are questions that, in bringing it out, we're going to have to answer. You know, I'm going to have to answer them. We're all going to have to answer them. So if we can get that information, it helps kind of build support for a model or not. So.
Absolutely, absolutely. If we choose to move forward. Thank you very much. Senator Austin.
Thank you very much. As all of you may know, I'm the chair of appropriations, and they've all been making digs at me. But relative to the model in front of us, I also have some concerns on the plan to on cost avoidance. So that's something that I'd like to hear a little bit more about. I also believe that any child who is in the middle of a mental health crisis is not going to learn. And so we got to figure out a way to keep those children within the confines of the school so that they have a connection and so they don't lose that connection, because I think what your model is doing is showing a connection for those young people. And I think that connection is one of the most important pieces for them to get stabilized and them to return to the world of learning. So I do appreciate that component of it. On both sides of the issue, what Representative Nuccio was saying relative to the cost avoidance component. And I do think that, you know, unless we figure out how to pay people who work in schools less, which I don't think we're going to do, our school budgets are going to go up. And that's just a real fact. We either have to get rid of some other costs or try to figure that out. That's the same thing in any budget that we have. If you have people that are within the confines of your budget, you're going to see an increase in the budget as their salaries and benefits increase over time. So I appreciate the model based on the fact that it's addressing an issue of someone who is not currently practicing avoidance by not coming to school, and let's try to keep them there so that they have an aspect of learning that is within the confines of their fellow students. So thank you. Thank you, Madam Chair.
Could I respond very quickly to the cost avoidance piece, because it's come up twice? I agree 100%. The cost avoidance, it's subjective. I talk to business administrators all the time, and we talk about hard cost savings, which is an actual observable reduction in the budget, versus soft cost savings, which is more of the cost avoidance piece. So our view on this from a policy standpoint is like the numbers need to square on the basis of the hard cost savings. And then the reason to do that pilot that we mentioned before is to be able to look longitudinally over a longer period of time to see if that avoidance that you're seeing is actually manifesting itself. And that's sometimes hard to see in just a 1 year period. Sometimes that takes a couple, 2, 3 fiscal cycles to really kind of observe that. So, but agree with the comments on cost avoidance.
Thank you.
Thank you so much. I know we've asked a lot of questions and oh no, sorry, I apologize. One more question. Okay.
I actually had 3, but I'd be willing to just ask 2 if that's really a rule or not. So you let me know. But the first one's pretty quick. One, can you just, one's about the organization, one's about your experience in Connecticut, the other one's about the study. About your organization, correct me if I'm wrong, I understand that you are an equity-backed private corporation. Can you tell me a little bit about the returns you're able to deliver to your investors?
So we are a privately held corporation. I can't really speak to returns. You know, we are a mission-focused, for-profit organization. Our top priority always is doing right by the students, families, caregivers, educators, and school districts that we service.
Thanks for that. Oh, and I just wanted to say, I do share your interest in reducing unnecessary out-of-district placements and also in blended funding for school mental health services. I think the village has some experience providing services within districts that are supported both by district funds as well as Medicaid billing. So I think that there are paths there. I agree. My second question is about your experience in Connecticut. Are there any districts, you've had some success in kind of engaging and partnering with more districts over time. Are there any districts that you engaged with and now are no longer engaged with? And you can tell a little bit about kind of why those relationships ended, if that applies to any of the circumstances?
Sure, absolutely. Yeah, and I wish that wasn't the case, but there certainly are districts that we've worked with that haven't been able to continue. The vast majority of the time that would be fiscal and budget kind of related. And the last 2 years, I think, has been a very, very challenging time for school district budgets. We're very thankful that the vast majority of our districts have been able to continue. As I mentioned before, we've really worked with a lot of them on financial sustainability plans, because I would say just about every district we work with recognizes the value of the services that are being provided. But it's really a question of how do we fund these services on a sustainable basis.
Does that mean that those districts weren't able to achieve that return on not sending kids out of district, saving enough money to cover the cost of the service?
It's a good question. So in some districts, especially during ESSER, we saw some districts implement the program. The out-of-district tuition piece doesn't just happen on its own. It takes a ton of coordination. We're working with the district right now where we partner with the district. We look at the roles of students out of district. They identify students who might be appropriate to return. There's a collaborative clinical review to review each of those cases and understand who can come back. So it's not a situation necessarily where the district wasn't able to realize kind of the savings. That next step of actually going through that process of identifying the students and systematically returning them in a responsible way just didn't happen. And districts are incredibly busy, and this is a big project. So this is something that it takes time and energy to take on. And I'm very empathetic with all of the challenges that school districts have facing them right now.
Thank you. My third question is just, I hope, a quick one, and it's really about the study. The high fidelity measure was really about whether they received the dosage for more than half of the school year. Do I understand that summary correctly? More than 50% of the...
Yeah, the high fidelity, I think the exact measure, and it's in the fine print here, was students who were receiving the kind of triumvirate of individual, group, and family in at least 33% of the weeks that they were enrolled kind of in the service. So.
And does that include kids who kind of came in later and kids who left earlier? Or like, why didn't they participate for the entire year? And do you know if...
Tammy, I'm sorry, I'm going to interrupt you because we do want to also give the floor to Fran Rubinowitz. And would you mind if we just... I apologize, I'm sorry. Don't mean to be disrespectful. Sorry. I apologize. But please send me your question and we can send it over to our presenter. Fran, would you like to, we want to give you the floor a little bit as well.
Yes, I'm just going to take 2 minutes because I've just, I think the discussion today has been amazing. And I want to go back to what Alice said. Yes, we are very, very responsible as the schools for the academics of kids, but we also know we have the kids, and the mental health of those children is the foundation for them learning the academics. I would love to have a longer discussion with you on preventative pieces. I love what the RESCs are doing. I think it's a longer discussion, and I know time is short, but I do think it's time for us to really think in education about breaking down the walls. We can't do this by ourselves. We need community organizations to help us. The CHDI, Clifford Beers, and Education School Solutions are just amazing groups that have really helped in stabilizing the mental health of kids. And that multi-level system of support, I have to tell you, I'm not sure that's on everybody's radar screen. We need to do some work there. And as one of the tri-chairs of the special ed task force, I will say to you that we lead the nation right now. We lead the nation in out-of-district placements. And I've heard a lot of discussion today about funding, and I know that that is important. As a former superintendent in Bridgeport, I certainly know funding is important, but I am coming from the perspective of what's good for the kids right now. And in my opinion, I understand that we have some children that need to be in out-of-district placement, but I think the best solution for the majority of our kids is to have them in our schools so that they can be integrated, so they can be part of sports, so they can be part of learning in a classroom for at least. So I think we really need to take a close look at how we can amplify in district placement, and I'm hoping that we're taking a really close look at it on the special ed task force, and we'll come back with recommendations on that. But I think this discussion could go on for 5 more hours, to tell you the truth. It's been an excellent one. Thank you.
Thank you, Fran. We really appreciate it. And I just want our friends here from the RESC Alliance, or did they leave? Well, I just wanted to point out the fact that they were the earliest part. It was a great presentation. We didn't go as deep on that. Obviously, this presentation on ESS stirred up a lot of questions. We so appreciate them. We appreciate you. We appreciate the work you're all doing to help children. And certainly we will be talking about it more because, as Fran said, we could have gone for quite a bit longer. I know everybody had a lot of questions. Thank you so much. Erica, do you want to handle how we're handling the end?
Yeah, so thank you so much. So the 2 last items of the agenda, we will move the update on the behavioral health investment. We'll move that over to September. And actually, this follows also with the question earlier about the school Medicaid waiver. That request had already been made to DSS, so there was already some motion to have them come and present on that. So that could be a really nice way to close that loop. In regards to the TCB strategic planning, what we're going to do is we're going to shift that over to an online survey. You will be receiving an online survey from Israeli. It has 3 questions. It's very short. 3 questions. We're trying to capture your input on what the mission should be or what the mission statement should state for the TCB. And so it's very short, very simple, 3 questions for you to reply to. You will receive it in a link. We will compile your input and bring it back in September. I do want to also let you know we don't have a meeting in August. There is no TCB monthly meeting in August. The work group meetings do take place, but not this monthly meeting. But in September, we have shifted the monthly meeting to be September 25th. And it is going to be, there's going to be an extension. There will be an in-person, you will be receiving this invitation before the end of this week, an in-person session here at the Legislative Office to go over the mission statement as well as identifying your goals. These are all the 2 other components that are needed for your strategic plan, and that'll be here from 12 to 1:30. We will have a 30-minute break, and then you'll shift to your regular TCB meeting, which will start at 2. So I wanted to give you that heads up. Thank you, everybody. I'll return it back to the chairs.
Are we closing then, or are we going to try to take those next 2 items from DCF and DSS? Because I know, I think in the interest of having, since our Medicaid director and Dr. Francis Gregory has been sitting through this excellent presentation, there's been such interest in the funding that has been, and I invite you to come up to the witness table so that you could share very briefly at a high level some of the investments that have been made in the ARPA stabilization package and the underlying enacted budget that we're moving into for FY25. As some folks will recall, there was $7 million state shares set aside for Medicaid rate increases, and then as part of the conversations this year, statutory language was directing the DSS to implement those $7 million for family inclusive therapies and children's behavioral health. And Bill Halsey can share the bulletin that went out in June talking about the codes that will be plussed up and the amounts of investments we made based on the Medicaid rate study. And then I invite Dr. Francis Gregory and Vin Russo to talk through the $10 million that was set aside in DCF of ARPA and $7 million for UCC stabilization, also ARPA. Bill, you're on first.
Thank you. Thank you. Good afternoon, everyone. Bill Halsey from Department of Social Services, State Medicaid Agency. As Claudio mentioned, in the recent legislative session, we were appropriated $7 million, state share $7 million, so more closer to $14 million to the providers to invest in the children's behavioral health system under Medicaid. And so I want to talk through how we did that. We get a lot of feedback from providers throughout the year, not just as part of this $7 million. So we targeted specific codes and services under that initiative. So we did a 15% rate increase for targeted procedure codes, 2 of which are associated with the evidence-based, home-based children's behavioral health services. So those are the ICAPS, functional family therapy, multidimensional family therapy, and one other. And then, so those are the 2 codes associated with the home-based services. We also did a 15% increase for family psychotherapy, and that would involve the child. And so another very child-specific service code. And then we targeted the specific code that technicians use to deliver autism services under Medicaid. We felt like that needed to be addressed as well. Then all other children's behavioral health procedure codes received a 3.75% increase through this funding. And that funding impacted many different provider types. Really, any enrolled provider that was delivering children's behavioral health services received those increases, as I mentioned. Just really also very quickly, and then I'll turn it over to the colleagues at DCF, there's other investments being done at DSS either through ARPA or Medicaid. So we had some ARPA funding to support the Connecticut Children's Medical Center inpatient med psych unit. We also invested in infant mental health under ARPA. And then under Medicaid, we were able to support 4 urgent care centers as well under Medicaid. And so happy to take questions on that or immediately pivot over to my colleagues at DCF.
I would just like to say thank you. Thank you, thank you, thank you, because this was really important and it was work that we wanted to have happen and an outcome that we were looking for. So thank you for your patience of sitting through waiting for this and also for the 15%.
Hi, good afternoon, everybody. My name is Vincent Russo. I'm with DCF. I'm sitting here with Dr. Frank Gregory, who oversees our children's behavioral health operations at the department. So very quickly, because I know we're short on time, we really appreciate the General Assembly's allocation to us this past session, $7 million for our urgent crisis centers, which are now stood up. The 4 that we have been previously approved are operational, and so that money will be used to continue funding them, along with the Medicaid rates that DSS has helped us secure moving forward, so that's good news. We also got a $10 million allocation for general children's behavioral health services. And we really looked at this from hearing the providers and hearing from legislators throughout the session, some of the key areas. And so we were really looking at, given this one-time investment, how could we best use these dollars? And so, and Dr. Gregory will get into more details, but we really put it into 3 buckets. We looked at workforce investments for providers across the board, in-home programs and how to incentivize those more providers going in the home, because we feel that children perform better and do better when they're treated in their home with their families. And lastly, again, due to ICAPS, where we can find ways to assist our ICAPS providers without stepping on the existing Medicaid reimbursement they already get. And with that, I'll have Dr. Gregory get into more detail.
Hi, thanks. Frank Gregory from DCF, and I'm going to look at Vin's screen here. So, as Vin said, the three groups, if you will, our intention was really to try to have this funding as equitably distributed and also to have the broadest impact. So in terms of the workforce investment across the board, all of our contracted behavioral health services received part of this funding. There were some exceptions related to if a program is strictly ARPA funded, some of the programs that are providing solely technical assistance, some of the programs that are currently under procurement. Those were not included in this distribution, but all of our, which represented 194 behavioral health contracted programs, received a one-time fixed amount. It was equivalent to 3% of their current funding. I say it that way because we want to distinguish between that and a percentage increase that's attached to the contract. It was a one-time concrete amount. On top of that, within those programs are these the intensive in-home behavioral health programs that we've referenced and that DSS referenced. So all of those programs got this initial allocation. And in addition, recognizing the challenges that they have faced, particularly in recruiting and sustaining their workforce, they received an additional funding investment, which represented about 5%, just over 5% of their contracted. So if a contract with MDFT, for example, would get a funding injection representing about 8% of their contracted amount, as would functional family therapy, et cetera. Now, ICAPS, we don't have contracts with ICAPS providers, and as you've heard, there's been a lot of work on DSS's part to enhance the Medicaid funding because they are fully fee-for-service supported. That said, we continue to discuss with the providers issues that are impacting their operations, their sustainability. So one of the things that came up is that they do have some fixed costs that they believe are not adequately compensated by some of the rates, particularly when they bring new staff on and activities that are required to really bring those staff fully up to speed before they can be fully generating the revenue with a full caseload. And so recognizing that the rate increases that have gone into effect, in addition to that, we use some of this funding. The ICAPS providers actually proposed a rubric, if you will, of larger programs and smaller programs and the numbers of programs around the state. So based on that, we made an investment of $1,890,000 of that money across those programs. Essentially, a large program got a certain amount, a quote-unquote smaller program got a different amount. And so together, the investment across the board and then the contracted in-home programs and then in the ICAPS programs with whom we don't have contracts, that is the investment of the $10 million. These funds need to be committed and expended by the end of December, so we're actively working with our fiscal and contracts department to really make that happen. Anyway, I know we're short for time. Happy to answer any questions.
Thank you, Dr. Gregory. And just a quick point, and then we have one question from Senator Austin, is that they're obligated by the end of this year, but they do have until 2026, end of the calendar year, to spend it, which will be helpful. Senator Austin.
Thank you. Do you have a map that shows across the state of Connecticut where the programs all are? Can you provide us with something?
We could map it. We certainly know where they are. I don't know that we have. I think we can. On connecting the care.
If you could send that to the committee, that would be perfect. Thank you. Thank you.
That's a great suggestion. Thank you. And if you could send it to Erica and the Tau folks, will circulate to the entire committee in our listserv.
Sure.
Perfect. Thank you both. Really appreciated, especially the work on the UCCs, which took initiation through DCF, standing them up through ARPA dollars, braiding them into the Medicaid rates, and having interim rates that are going to be a continuing and permanent source of support, but also recognizing we need a little bit more of bridge funding. So I think that was a great interagency collaboration. Thank you all.
Yes, thank you very much. This was wonderful news to hear, and thank you for being patient, but well worth the great news that you came with. And thank all of you for staying a little bit extra. We were all kept awake because it's absolutely freezing in here. But thank you so much, and we have August off, so we will see you in and we'll see you in September. Have a good afternoon.